Hello and welcome everybody to today's webinar, a review of eye tracking in retina applications. I am Ulrike Rahn, clinical manager at ODS, and I'm happy to see so many interested in navigated retinal laser online today, despite we are facing still difficult times. In the next approximately 30 minutes, we will give you an overview of the use of eye tracking in ophthalmology with a very special focus to retinal laser. This will include a short review of the current evidence that is in the literature. I'm happy to welcome today's presenter, Dr. Igor Kozak from the Moorfields Eye Hospital in Abu Dhabi. Dr. Kozak is one of our first users and has made experience with very early product versions of Navilas, providing us with many helpful and constructive feedback. During this very long-standing cooperation with Igor, many publications became available, and Dr. Kozak was following them in the past and will be summarizing these information today for you. His short presentation will be followed by a question and answer session. To type in and send your questions, please use the chat window of the webinar application. We will answer as many questions as possible during the question and answer session. Any remaining questions not fully covered today will be answered offline after the webinar. So don't worry if your question had not been selected, nothing will be missed, we will answer them afterwards. But now let's get started with the presentation. It might take a second to hand over, but we are now going to hand over to Igor Kozak and the presentation.
Hi, my name is Dr. Igor Kozak, and I work at the Moorfields Eye Hospital in Abu Dhabi in the United Arab Emirates. And I will be talking today about the navigation technology in ophthalmology with a special focus in retinal applications. Navigation technology as such is a very useful and practical advancement and is present in basically everyday life, such as transportation and deliveries, and medicine is no exception. Several medical areas are using navigation inputs in diagnostics and in surgery, such as urology, neurosurgery, ENT surgery, and ophthalmology is no exception to that. So eye tracking or navigation in ophthalmology covers all anatomy of the eye and covers both anterior and posterior segment. In anterior segment, the majority of application is focused on refractive lasers and corrective surgeries, where navigation has been revolutionary. And similarly, in placement of intraocular lenses during cataract surgery, navigation has enabled surgeons to perform much more accurate surgeries. So in posterior segment of the eye, of course, retinal imaging has been using features of navigation to stabilize the structures that we are imaging and then using our diagnostic approaches for. And another area using navigation is laser treatment for retinal diseases and also some surgical approaches. So I will be briefly covering you with all the updates. So let's look at brief history of eye tracking in ophthalmology. It dates back to 1990 with the first attempts to use eye tracking and navigation in refractive eye surgery. The real practical impetus comes in 2000 where wavefront guided eye tracking was introduced and has been popularized in LASIK and photorefractive keratectomy surgeries. Then we are moving on to diagnostic application with Ferguson and others using eye tracking for imaging with optical coherence tomography, and then these quite sophisticated six-dimensional eye tracking and publication by Bühler and others, where not only X Y, and Z is taken into consideration, but also rotational movements of the eye globe. And then, of course, the advances with the SMI and introducing eye tracking into direct implant surgery. The latest application is in retinal surgery and retinal photocoagulation with ODOS, where all this fantastic technology has been applied to assist in more accurate laser photocoagulation. And of course, we are asking and looking into all clinical benefits of this approach and what this technology has given us over time. So here is a scheme of how eye tracking works for anterior segment of the eye and tracks the eye movement during refractive surgery. And then we have the outcomes where the red line represents the ideal surgical outcome, and here we can see that using this technology, treatment outcomes very closely oscillate this ideal line and are staying away from overcorrection or undercorrection zones. In cataract surgery, the navigation is used for correct placement, especially with toric intraocular lenses. And here we can see the results with residual refractive error. And what we can observe is that when we go to the very minor refractive errors and really fine-tuning of the vision after cataract surgery, that image-guided implantation produces much more accurate results and desired refraction after cataract surgery. So in retina, we are also using eye tracking very effectively for retinal laser photocoagulation. And let me show you an example of photocoagulation. Here we are using digital imaging of the retina and are creating a treatment plan for panretinal photocoagulation. And then this treatment plan is a basis for actual in vivo photocoagulation. And this is what is called pre-planned approach to retinal laser photocoagulation, which can be used both for posterior segment disease and peripheral disease, such as in this case. And the yellow circles show protective zones where we do not want the laser to be applied. And this is all done in vivo with actually online navigation. So much usefulness of this technology. Now, there is an increasing body of evidence based on published manuscripts in peer-reviewed journals of the use and usefulness of this navigation technology for retinal application, with the first publication of Ben Liesfeld, who grounded the engineering basis for this technology, and then further on with clinical application in various retinovascular diseases such as diabetic retinopathy, diabetic macular edema, vein occlusions, central serous retinopathy, and others, in which the authors were reporting on clinical outcomes, on safety, on accuracy of treatment, on pain and comfort during the treatments. And as we can see, there is too many of these applications by authors from all around the globe, pointing to the increased popularity of using navigation in retinal treatments. Let's go over some literature pointing to the practicality of application of navigated laser. This is a study published in IOVS, which compared two laser systems and two parameters in terms of speed of treatment, and concluded that using navigation in peripheral laser photocoagulation, we can treat patients faster, which eventually will result into less discomfort and less pain. And this are other publications by different groups showing decreased pain and increased comfort in both posterior segment disease, such as published by Marcus Kern, or then in peripheral retinal disease, such as paper by Amoroso, who also compared different laser system and concluded that the portion of pre-planning and creating a plan which is allowed in navigated laser is a decisive element in making faster and less discomfortable treatments. Of course, we are focusing on increase in accuracy, which is the basis of eye tracking and navigation. And the original paper looking into the accuracy published in ophthalmology showed that navigated approach outperforms slit lamp-based conventional laser in treatment accuracy with high statistical significance. And this was also reproduced in another study, which showed that majority of the eyes had very accurate treatment within 100 microns of pre-planned treatment area, which is not usually happening with conventional laser. And in addition to that, the completeness of treatment is higher when using pre-planned photocoagulation as opposed to ad hoc conventional slit lamp approach. Again, navigation significantly reduces retreatment, and this study clearly shows that in laser photocoagulation, sometimes we need to retreat the pathology, and when using this targeted approach with a pre-planned photocoagulation, we are able to reduce the number of subsequent treatments that are necessary to achieve the desired outcome. And this is also a very important feature that eye tracking adds to clinical application. In addition to that, investigators have looked into combination therapy of navigated photocoagulation, anti-angiogenic agents, and the protocol contained a loading dose of 3 injections with dichotomization of treatments following that phase into monotherapy with injections and addition of navigated laser into the treatment. The results are showing that the number of injections following loading dose has decreased in the navigated arm, and also was decreased the retreatment rate, and some of the eyes that received navigated laser did not need any more rescue injections. So this was statistically significant, and the same group continued follow-up for up to 4 years, and they have demonstrated that the initial results of reduction of additional injections has actually stayed along the follow-up study. So conclusion being that more accurate treatment achieved by navigated photocoagulation has a longer effect and will lead to reduction of subsequent injections, which is what we want to see in these chronic diseases. Several other groups have found this interesting concept, and some were able to reproduce the results. What else can we do with navigation? We can use this for microsecond pulse photocoagulation or photostimulation, I should say, which is another mode of laser delivery that has been gaining popularity, that can be combined with navigation, which we believe accentuates its strength. A study published in Clinical Ophthalmology using the set parameters, very important 5% duty cycle, and in this paper using yellow wavelength, showing that the leakage can be significantly decreased and the resolution of subfoveal fluid in 3 months reached 60% in this cohort. This is just a review of papers on central serous retinopathy that has used navigated laser approach either with a continuous wavelength or in micropulsing mode. And here we can see the percentage of complete resolution in these publications. So again, we are starting with planning and covering the areas that we must not approach. There are different ways depending on physician's preference of whether the treatment will be a grid treatment or a focal treatment. The advantage of this pre-planning and navigation is that in case of micropulse, where we do not have any orientation point, we still can clearly identify the treated area, and we can keep that record for future treatments if necessary. And the documentation is very important in retreatment of the specific area. So this all is available with the image-based eye tracking system. And this is actually additional feature that we do not see in excimer laser treatment plan. Another application of retinal navigation is that it can be used in telemedicine. And telemedicine or teleophthalmology has become so important in these days because of the worldwide epidemic and many of the consultations being turned into these remote consultations. And this is a proof of concept how navigation is essential in doing these telemedicine treatments. And what happens in this is that the image is sent to a reading center or to an expert who will create a treatment plan. And this treatment plan is then returned to the center which needs to perform laser photocoagulation. And this can, in a coordinated way with data protection, is an elegant way of using teleconsultation in the accurate treatment of the patients who are in need. Navigation platform is also used for education of physicians and medical students. And we can now use an iPad with a retinal image in which the physician or trainee can create his or her own treatment plan, which is then consulted with a senior physician, and this can be used for future education. So navigation is a technology that opens up application within the area of retinal diseases and ophthalmology as such. It has brought us lots of useful information. It has increased the quality of what we do in anterior segment application. It has definitely improved clinical outcomes and reduced the variability of the results. As a matter of fact, excimer laser surgery is probably the most reproducible surgery of all surgeries ever, because it totally depends on the nomograms and is basically independent of a surgeon. Then navigated laser photocoagulation in retina has revolutionized the approach of how we can perform retinal photocoagulation, and with the possible import of all the images and imaging modalities, we can now perform much more accurate treatments. We can reduce the need for retreatment. This pre-planning makes the treatment so comfortable that the treatments are very fast, and as a result of that, they are more comfortable and less painful. Of course, with all other additional features that and laser power deliveries that can be applied to laser photocoagulation, it can all be done in conjunction with eye tracking and navigation. This is just a fantastic opportunity of how to move forward and make our treatments safer, faster, more reproducible, and more accurate. And with that, I would like to thank you for your attention, and I am happy to answer any questions you might have.
Thank you, Dr. Kozak, for this really in-depth presentation. I'm really happy that we had the chance today to conduct this webinar with you. And I think we will now move on to our question and answer session. As a reminder to the audience, To type in and send your questions, please use the chat window of the webinar application. We will try to answer as many questions as possible. If your question was not answered today, we will do that offline after the meeting. Dr. Kozak, are you ready to take the first question?
Yes, Ulrike, please go ahead.
Wonderful. I already have the first question here. It's about the recently published T-Rex trial. There was a T-Rex, most recently the T-Rex 3 years data have been published that analyzes the treat and extend regime in DME. And this study also contains one arm with a navigated laser. Could you summarize this study and provide us with your thoughts on it, especially on the results?
Yes, thank you for the question. So this is another study looking into combination therapy of laser and injection against monotherapy. In addition, it also looks into fixed regimen of injections and treat and extend regimen in which we are extending the intervals once the anatomy or functions have been stable compared to previous visit. And what was shown in this study that addition of navigated laser does reduce treatment burden in comparison to the treat and extend monotherapy arm. It also showed trends towards a better anatomic outcome, and however, it did not reach a statistical significance. So the latest data that we have is on 3 years, and the data basically has not changed over the 3 years of follow-up. There was no compromise on visual acuity, there was no safety issue or any red flag in any of the arms. So basically that's another clinical trial looking into combination therapy. In addition, it has shown that there is a decreased treatment burden at year 3, most pronounced in guided image-guided laser arm, in addition to injections, and there is increased cumulative clinical benefit. Again, bearing in mind that anatomy only showed the trend and not real statistical significance between arms. So that's the latest of the combination trials. Does that answer your question, Ulrike?
I hope it answers the questions from the audience, and I think it was a very intense answer, so I hope it will answer. If not, please don't hesitate to add a second question on that one. In the meantime, I just saw another question a little bit related to that, especially considering all those results. When do you use the navigated laser most often? For cases of PRP, CSER, DME, what is the indication that you prefer it most and use it most?
Well, I use it whenever I need to use accurate and safe laser. And so basically in all combination, and my practice basically reflects, you know, the epidemiology of any retina practice. So most common is diabetic eye disease, be it diabetic macular edema, peripheral retinal disease, proliferative retinopathy, other retinovascular diseases, vein occlusions, sometimes macroaneurysms that need photocoagulation, of course, central serous chorioretinopathy. I also have to stress that I have switched into using lots of micropulse laser into sort of, you know, photostimulation rather than classical photocoagulation, but that's a different topic. Actually, all retinovascular disease that need addition of laser or are primarily treated by laser, I am happy and ready to use navigated technology.
Yes, thank you. You just mentioned microsecond pulsing laser, which would bring me to the next question. Can the microsecond pulse laser be directly applied to the foveal zone? And if yes, which parameter setting would you recommend for that?
Yes, it can. And of course, there is a learning curve to that, and it depends on pathology. The paper that basically clinched this concept was published in Retina by Jeff Luttrell and Steve Sinclair, who presented with the largest cohort of patients treated transfoveally. And the most important is 5% duty cycle. That's the most important, preferably 810 infrared laser, but I understand that also yellow laser can be used with adjustment of parameters. And for a long time, I was hesitant to use transfoveal, but I have treated lots of patients with transfoveal, and again with safe parameters, that's possible treatment.
Perfect, thank you. One point which you also made, it takes some time to learn it, which actually brings me also to the next question. It's about learning. It seems to be a relatively complex system. What do you think about the learning curve? Does it take long to understand how to use it?
Well, thank you very much for the question from audience. And what we are noticing is that younger generation of ophthalmologists, especially those who are used to, video games and navigating, using handheld devices, have no problem at all. The system is camera-based. It's not a typical slit lamp delivery. So anybody who can take a retina photo or who can play video game will have no problem navigating, and bear in mind that apart from panretinal photocoagulation, you do not need to use contact lens for this treatment. So this is entirely contact lens free treatment. Which actually adds to less discomfort and better treatment experience for the patient. All you need to do is to be able to focus the image, and then you have offline part, which requires placement of or selection of the points which you want to treat in the retina, and just coordinating it all. The learning curve is really very steep, means you can master the technology very fast. It would translate into 5 to 10 eyes at the most.
Okay, thank you. We had been earlier talking on microsecond pulsing laser. If I understood you correctly, you use it also in CCR, also according to the presentation. I would like to combine two questions from the audience. The one is probably the first one better. What's your tactic in the treatment of CSC with Navilas? And what is your experiences in the result? When and how do you treat patients?
Well, central serous retinopathy is a complex disease, and it depends whether you are treating, the first attack, or if it is a recurrent disease. How long has the disease been there? We need to look at the status of retinal pigment epithelium and the pumping activity. So there are many factors. As we know, the Navilas system uses 577 wavelength, so that is to be used. And again, 5% duty cycle I'm using with the all micropulsing, 0.3 seconds. The power is adjustable by usually somewhere around 425, 450 milliwatts. That's based on prior publications and calculations, experience from users, and that is all well published. I am switching into using panmacular as opposed to just focal or minimal. Actually, there is a ongoing clinical trial where we are recruiting patients comparing panmacular treatment versus minimal treatment. But these are basically the parameters that I have mentioned. Similar parameters would apply to 810 wavelength. And then, as we know, sometimes this pathology requires retreatment. So it's not uncommon that we may need to treat 2 or 3 times to achieve complete resolution or even reduction of subretinal fluid.
You were mainly talking about the microsecond pulsing laser. Are there situations that you use or in which you use the threshold laser for CCR, either as additional or as primary care?
Thank you very much. I still do, yes. If there is a focal leakage, as shown on fluorescein angiogram, I just use a focal photocoagulation as opposed to sort of this diffuser, panmacular micropulsing. So you can elegantly use, especially with this highly accurate Navilas system, with just one shot, you can elegantly close the leaking point, which will lead into resolution or reduction of the subretinal fluid. Advantage of navigated system is that you have everything documented. Okay, so irrespective of whether you are using photocoagulation, the single spot focal laser, or you are using sort of diffuse, grid treatment, you actually have exact area mapped out with energy parameters and other parameters, which is in your machine, and then you can either reapply or you can change parameters if you need to treat second time. So all these features are very important in follow-up and subsequent treatment of these patients.
Thank you very much, Dr. Kozak. Unfortunately, we are already past the 30 minutes, so I would think that we are unfortunately now running out of time. There are a few questions remaining that we will be answering offline and afterwards. So before everyone's dropping off, thank you very much again, Dr. Kozak, for being available today. Although we all have to handle many things at the moment, it was a very interesting presentation and discussion. I enjoyed following the webinar today a lot, and I hope that the audience feels the same. We will inform everyone when the on-demand webinar of this, or on-demand version of this webinar will be available. In the meantime, if you are interested in more clinical experiences or webinars held before with about navigated laser, please visit our website at www.od-os.com/experts. Thank you very much for this webinar and for your attendance, and I hope to see you soon on one of these hopefully recovering conferences next year or in a direct personal discussion. Thank you very much.
Thank you, Ulrike.